So good afternoon, everyone. I am Dr. Virbhan Balai. I am working at Manipal Hospital, Dwarka, New Delhi in India. I will be showing a case of cath lab complications where unfortunately a wrong sequence of events happened. So I don't have any financial interest or disclosure related to this case. So our patient is a 69-year-old lady who presented to ER with complaints of retrosternal chest pain, which was radiating to the bilateral arm since last 6 hours. She is also a non-case of diabetes and hypertension. For that, she is on the treatment. And this was her ECG obtained in the triage at the time of presentation, which showed the ST depression in the inferior leads and in the V4 to V6. But her echo done on the bedside showed normal LV function with no regional wall, and her LVEF was around 60%. Her troponin I was normal. Her serum creatinine was 0.9, and her GFR was around 70. So in view of acute coronary syndrome, after informed consent, she was taken for a diagnostic coronary angiogram through right radial artery approach. So here we can see in the areocaudal view that in the mid-LAD there is tight around 90% lesion. And in the cranial view, we can see that there is another lesion below D2 as well. And the right coronary artery was non-dominant. So in view of symptomatic ischemia, we decided to fix this LAD lesion. So it was right radial artery approach. The EBU 3.5 or 6 French guiding catheter was taken, and the 2 normal workhorse guide wire was parked distally in the LAD and in the D1. And then it was started to predilate the lesion with 2 or 10 mm NC balloon sequentially from distal to proximal at 12 to 14 atmospheric pressure. But then after predilatation, it was seen that in the mid-LAD, the patient had the slight staining of the contrast with no flow. So whether there is dissection or it's in thrombus which got embolized. So thinking that probably the vessel got dissected, we decided to fix this vessel with 2.5 or 28 mm dash, which was deployed from mid to distal LAD at 12 atmospheric pressure. But even after keeping this stent inflated for prolonged time, and even after inflating the stent twice, the distal lesion did not give away. So probably the vessel was not properly prepared, and when the patient had no flow, so we deployed this stent. So we thought that this lesion we will optimize at the time of post-dilatation. Let's fix the proximal lesion. So another dash 3 or 48 mm was deployed from the proximal to mid, overlapping with this previously deployed stent. And then we started post-dilatation with 2.5 or 10 mm NC balloon. And at the time of post-dilatation, patient had grade 3 coronary perforation. So immediately balloon tamponade was done with the same balloon, but we thought that in grade 3 coronary perforation, it won't seal by its own with the balloon tamponade alone. So immediately the graft master 2.8 to 19 mm was taken, which was available in the shelf at that time. But when it was inflated, the stent did not open well, this covered stent as well. And patient did got crashed, so immediately the CPR was started as per ACLS, and the immediate pericardiocentesis was done just to stabilize the patient. Patient did got stabilized, and patient had flow distally. The covered stent was also deployed, but proximally there was some hazy eccentric lesion was seen. We thought that probably it could be either dissection as guide was engaged while CPR was going on. So either it could be the guide induced proximal dissection in the LAD or maybe concentrina, but it did subsided. It resolved after giving few NTG dosage. And then the check angio was done. That the bedside echo was done, that did not show much of collection in the pericardial space. But patient's pressure started dropping again on the table. So we decided to have a look at the right femoral artery access site. Though the procedure was done through the right radial artery approach only, but what happened is that when the patient did got crashed, the another operated started taking the right femoral vein access just to insert the TPI, but inadvertently he took the right femoral artery puncture. Though it was realized that it's an arterial puncture, but anyhow the sheath was inserted, thinking that probably it could be utilized later on when we may have to switch from the arterial to femoral approach in case it's required. So what we saw is that the bladder is pushed towards left side, so probably there is retroperitoneal hematoma. But as no active extravasation could be seen from the large vessel, we thought that probably some blood could be trickling from the small vessels, but we couldn't make out it. So we asked to have a look to the vascular surgeon, and after careful look, the vascular surgeon opined that it's better to manage it conservatively as of now. So as patient did got stabilized, we shifted patient to the CCU. But in CCU, patient never got stabilized. Her hemoglobin kept on falling, and she had poor hemodynamics. So, and in the CCU, the critical care guy also said that patient had a pouch of collection in the pericardial space as well. And we asked the vascular surgeon to have a look again. And patient was shifted to the cath lab again within an hour, just to have the relook again at the right femoral excess site. But again, we could not make out any active extravasation. But anyhow, the vascular surgeon decided that let's do the balloon tamponade of this right femoral arterial excess site. So the 6 or 80 mm balloon, the balloon tamponade was done at low pressure. But we couldn't achieve much. Only thing is that we created one more dissection distally, but as it was not flow limiting, we decided to manage this as well conservatively only. At patients, hemodynamics were not good on the table, so we decided to have a look at the coronaries as well, though PCI was done maybe around an hour back only. But when we took the check angio, the patient had an acute stent thrombosis. The distally vessel is not flowing, and here we can see that proximally also the proximal artery is dissected. Probably we already missed it when we gave NTG and all, it did got subsided. So just to open the vessel again, we post-dilated the stent again with 2.50 10 mm NC balloon at high pressure and proximally with 3 or 10 mm NC balloon. And then we also fixed this proximal lesion with 3 or 18 mm DES balloon at 14 atmospheric pressure, and subsequently it was stabilized. Though we could have used the intracoronary imaging at this time, but the cath lab in which this case was done, we don't have that the coronary imaging, either IOS or OCT. And then this was the final result. So, and then after this started the stomy session of the patient, went into the sepsis and the septic shock, acute kidney injury and DIC, but at the end everything settled down and patient was discharged subsequently in stable condition with normal serum creatinine. So learning point from this is that probably the meticulous and proper planning, proper reading of the angiogram is essential before planning the patient. The intracoronary imaging could be used to guide the procedure. We could have probably disengaged at the time of CPR, the left main, and it's better to have the look at the right femoral site also before shifting the patient. So I think that's it. Thank you so much.